morning, good afternoon, good evening, everyone. My name is Assis Malaquias. I'm the president of the Global Strategic Platform. It gives me great pleasure to welcome you all to the Africa sessions. The main objective of these virtual conferences is to foster analytical dialogue between experts on critical and timely themes. The theme for this session is COVID-19 and the resilience of healthcare systems in Africa. Over the past year, as we all know, COVID-19 has fundamentally challenged many of the assumptions we often took for granted. At the domestic level, the pandemic continues to stress test the social contract in many African countries. For most African countries, COVID-19 is a real reminder that the continent still faces challenges and vulnerabilities that require deep strategic thinking and forward-leaning leadership. And on the deep strategic thinking, this is really the reason why we're here, and we have invited a distinguished group of individuals to offer their perspectives on this topic. I will ask the two moderators, Mr. Chico Laxmitas and Ana Fernandez, to take over, introduce the speakers, and moderate the panel. Thank you very much.
Thank you very much, Assis, and thank you very much everybody taking part, and also to the audience for taking the time to join us in this, what is our 12th Africa Sessions event. We have distinguished speakers, as my colleague Assis was saying today, and I'd like to introduce one by one. Jorge Moreira da Silva, Development Cooperation Director at the OECD. Arnia Markham, who is MPH Vice President of the International Board of Doctors Without Borders, Médecins Sans Frontières. Giuliano Russo, Lecturer of Global Health at Queen Mary University of London and Associate at the Global Policy Institute. And joining me as moderator is Ana Fernandez, Head of Foresight Outreach and Policy Reform at the Development Cooperation Directorate at the OECD as well. Thank you all for joining us. Our session has essentially three stages. First, we will have a keynote speech by Jorge Moreira da Silva. Then we will have a session of questions and answers prepared by us moderators. And finally, a good half an hour to debate and do some follow-up questions. Jorge Moreira da Silva, thank you for being here with us. I know you have other commitments, so I'll just go straight to your pulpit and your initial remarks for setting the scene on this topic.
Thank you, Shrish. It's great to be with you and with all colleagues today. I really would like to thank the invitation for the Africa session. As you know, the DCD, the Development Cooperation Directorate, is the secretariat of the DAC, which is the constituency of the traditional donors that provide support to developing countries. And obviously in this context of COVID, and on the recovery, the role of the DAC and the role of the donors, it's even more important than ever. And Africa is indeed a priority, must be a priority. It should have been already a priority before. Now with COVID, there is no excuse not to address the support to Africa as the most important priority in this context. The COVID-19 virus, as we all know, unfortunately has killed millions of people globally and brought economies to a standstill. It has also underlined how dependent all sectors are on the health sector, and that the weaker health system becomes, the greater the risk of falling further behind, with profound implications for economic progress, trust in government, equality and social cohesion. Containing and mitigating the spread and the infection rate of the virus continues to be essential. This is happening now, but so is the strengthening the capacity of health systems to respond swiftly and effectively. This includes capacity to administering the COVID-19 vaccines. After lightning speed development and testing, vaccine campaigns are rolling out in many countries, but questions about production, delivery, and equitable access remain, not least for low and middle income countries in Africa. Well, over a year into the pandemic, we continue to see health systems stretched to the brink, and the pressing need to make more resilient and future-proof. Nowhere is this challenge greater than in Africa. According to the latest WHO data, less than 2% of the 690 million COVID vaccine doses administered to date globally have been in Africa. 2%, less than 2%. For those African countries which have begun vaccinations, the pace of vaccine rollout is not uniform, with WHO's Africa office estimating last month that 93% of the doses were given in just 10 countries. So the problem is not just about the 2%, it's also about the 93% that are concentrated in just 10 countries. And it is not just about unequal access to vaccines. People in low income countries in Africa are 100 times less likely to have access to tests than people in high income countries. And many countries are also experiencing shortage of oxygen and other essential therapeutics. There are mixed messages about how badly Africa's population have been hit by the pandemic when it comes to the total number of cases and deaths so far. We also know that we have issues regarding data collection, and that's why we have been also working with our members at OECD for a data for development agenda, making sure that the donors provide support for the statistical offices in developing countries on data, and also using the big data and artificial intelligence approach to manage this lack of information. Compared with other regions of the world, official data shows a lower rate of infection and death. But again, as I mentioned, the lack of data makes such comparisons difficult. There are now new warnings about the potential devastating impacts of the Indian variant on the African continent. Moreover, a study published in the Lancet last week showed that seriously ill COVID-19 patients in African countries were more likely to die than those on other continents, most probably due to the lack of critical care equipment. This same study from Lancet, which followed the coronavirus patients admitted to intensive care units across 10 African countries between May and December last year, also found that the mortality rate of those who get sick could be even higher than the figures suggest due to the lack of data. So I'm insisting on this issue of data. Almost half of the 3,000 patients followed during the study died within 30 days of admission, compared to just under a third of deaths for critical ill patients in Asia, Europe, and Africa. Overall, the authors of this Lancet study found that the ability to provide sufficient care was compromised by a shortage of critical care beds and limited resources within intensive care units. So based on this quite difficult findings that of course has an impact in our own perception of what is happening, the question is, so what can and should be done? Part of the solution lies in new and additional health financing targeted at those countries who need it most. Here, there are some good news. I would not exaggerate on this. There is no room for complacency, but I would like to share at least some positive trends, not sufficient, I insist, but positive trends from ODA, the Official Development Assistance. The ODA rose in 2020 to its highest level ever at $161 billion, for the DAC, Development Assistance Committee countries. Within this amount, 12 billion was spent in supporting developing countries face the COVID crisis by helping them manage the spread and the consequences of the virus. So you can see that from the 161 billion provided from OECD countries to developing countries, 12 billion was targeting COVID crisis. But this crisis is not just about dealing with the immediate consequences of the virus. It's also dealing with health systems, humanitarian aid, and food security. Also making diagnostics and vaccines available to countries most in need, particularly through the ACT accelerator mechanism. So this was part of the support provided by donors. Within these flows that I just shared, more ODA went to Africa than to any other region. Preliminary data showed that support from DAC members to Africa stood at 39 billion, representing an increase of 4.1% in real terms compared to 2019. Despite this strong focus on Africa, there are room for improving its support for the most fragile countries which were hard hit by the pandemic. Unfortunately, net ODA to sub-Saharan Africa fell by 1% in real terms. So you can see that there was an increase of 4.1% to Africa, but a decrease for its component to sub-Saharan Africa. This really represents a worrying trend in view of the health and economic consequences of the pandemic in the region. Other important news, we released also new data from a new measurement tool. It's called TOTSD, Total Official Support for Sustainable Development. And this new measurement tool, I don't want to bother you with the technicalities on statistics, but ODA just measure north-south flows. And it does not include neither the South-South cooperation or triangular cooperation, brilliant work that is being led by Anna, also the private sector and the global public goods. None of this is included in ODA. So we develop a new measurement tool that includes all these other flows, including the contribution to global public goods. So why am I emphasizing this dimension? Because the global public goods were until now somehow invisible in development finance statistics. And now we know from the data that we just presented that in 2019, there was $297 billion of TOTSD flows, which includes 28.2 billion that went to the health sector. So you can see that 28.2 billion, it's more than the amounts that ODA measures on support to health. So somehow there were some figures that were overlooked, and now with the new measurement tool, we are capturing it. But ODA and TOTSD financing alone will not be enough, even if accompanied by possible debt relief measures that have been asked by several African governments, debt relief. We also need urgent support, urgent efforts to strengthen health systems and increase their capacity. Low-income countries have fewer health workers per capita than in other countries. I'm sure that colleagues in the panel will provide more information on this. We also need more context-driven solutions. The vaccines available via the COVAX AMC mostly require refrigerated storage, and in most cases multiple doses, a key constraint for many countries, particularly where electrification levels are low. So the idea of equal access to vaccines is different than equal access to vaccination. So it's about vaccination that we should be talking about, knowing that the access to the vaccines doses, it's just one part of the bigger problem that includes this infrastructure and health systems capacity. In addition to these challenges on health infrastructure and vaccine supply, we are also seeing many issues with the vaccine hesitancy in Africa, particularly in some of the most fragile contexts where demand and uptake depend on transparency, trust, and understanding the benefits of vaccines. Meaningful community engagement and the Médecins Sans Frontières has played a very important role in this context. So this meaningful community engagement, particularly with marginalized groups or with communities who have low levels of trust in government services, are crucial to successful and equitable uptake of vaccines. The ongoing COVID crisis is leading the international community to reassess its approach. So I'm almost concluding, Chico. This new approach from the international system to health finance, as well as the approach to provision of global public goods in general. Several comprehensive review processes have been commissioned to look at the lessons learned from the international response to the crisis. The most prominent of these are the UN's independent panel for pandemic preparedness and response, and the G20's high-level independent panel on financing the global commons for pandemic preparedness and response, both of which are expected to help drive reforms. But what does it mean, health reforms? First, we expect a new demand for international cooperation and financing around global public goods. So additional finance coping with new demand is a fundamental element. These issues are explored in our recent OECD Development Cooperation report. Secondly, we can expect demand for better data to measure how financial flows can address critical risks and respond to needs as they emerge in developing countries. And again, as I mentioned, we are providing this new data beyond ODA through this new measurement tool that includes also private finance and contribution to global public goods. Finally, it will be critical to ensure that the additional financing we need for the health sector is not diverted from other sectors. So the additionality dimension is critical. COVID has not put on hold other health problems that we face or other problems that Africa faces on climate, on forced displacement, on education, on governance. So we really need to ensure that we are dealing with additional mobilization. The additional billions in development finance to address the COVID-19 crisis must be considered in the broader context of estimated trillions lost through GDP decrease in recent months. So this is especially important given that the pandemic is estimated to have set back progress towards many of the goals by up to 2 decades. Overall, the international community in general and development cooperation providers in particular have a unique role to support the poorest and most vulnerable countries to respond to the crisis and build back better. But let's be clear, and I'm concluding, this is my last sentence, the approach not only benefits all countries, it's also the only way forward, and I look forward to continue this collaboration and this discussion where the interdependence and the interconnectedness of the crisis can be a game changer to make this Sustainable Development Goals agenda an inspirational agenda for international partnership. Thank you very much.
George, thank you very much for such an excellent start to this event. Very insightful and wide-ranging analysis of the challenges that we face in the health systems in Africa, and many of which, as you said, will be discussed here in the panel, which we now start. Thank you very much for taking the time to be with us. Thank you, George. We will now move to the second stage of the event, which is a question and answer part, where we have 3 questions which we'd like to ask our members of the panel. I will start with a question about previous crises. What have we learned from previous health crises in Africa? I'll start with Aine Markham from Médecins Sans Frontières. What did we learn from the previous health crisis that can bring us help in understanding how to deal with the current one?
So that's an interesting question, and it depends, I think, on where you are in the world. And I think in some parts of the world we learned very little. And we saw that in how countries where we would have expected and that previously had been considered to be pandemic ready really didn't react very well. And I think that we should give some credit where credit is due, whereby we did see in certain African countries that they have genuinely learned and were able to apply the knowledge that they learned from previous outbreaks and epidemics that they have had. And that included, already mentioned by Jorge, the independent panel that has come back and said cross-sector approaches in governments and external to governments, early engagement of communities, working with communities to allow them to genuinely engage and work in very basic infection control to reduce community transmission. We did see these in multiple African countries, particularly in places that had had Ebola or have had other outbreaks. However, internally of what what I think the donor community or the DAC donors or what the international community has learned, I think that we need to learn that we have a lot of the knowledge and understanding that is necessary to address this pandemic and bring this pandemic under control. Jorge also mentioned that we understand that there's a lot of competing priorities within the healthcare systems and the populations in Africa. And how are we going to address that and what do we need to do? So I think first and foremost, we should really support early community engagement. So in a fully transparent way, we should have much more faith in what communities can bring to health system development and to health service delivery when they're properly informed and when they're supported to be engaged. I think it's important that we have also learned, unfortunately, where the open science approach that we saw, which is really to be endorsed and commended, also gave us problems in terms of misinformation and disinformation. So helping communities and helping governments to address that, because also mentioned by Jorge that the independent panel on pandemic responsiveness and preparedness shows that undervaluing science and the denial and distrust of science spread through media and through also governmental sources. So with regard to poor leadership, the denial and lack of recognition of what needs to be done and not using tools that we have in our toolkit, such as pandemic preparedness, which is actually exists and did exist prior to the present pandemic, but has not been really engaged in a proactive manner or in a manner that has allowed us to manage this pandemic as we should have. So I think these are key issues. I think that's also very important to embrace known factors that we've seen in the past have actually supported better health outcomes of populations and patients. So, for example, we see now a big conversation across the world on international property waivers, on technology transfer, again on open science approach, but also on boosting supply and manufacturing capacity within Africa itself. So, removing this ultra dependence on others to supply. And we saw this particularly at the beginning of the pandemic, where the world found that it was very dependent on one or two countries, in particular China and India, for pharmaceutical, what we call active pharmaceutical ingredients. So just to make pharmaceutical products and also things such as protective personal equipment and really healthcare equipment and products that were essential to address this pandemic, but which were not available and are still not available in many cases at the level that they are needed, nor affordable within many countries in Africa. I also mentioned by Jorge, and I think really important to understand, is one of the major lessons that we have learned is valuing people. And how do we value people? And that includes addressing known healthcare workforce gaps. So in particular, we see big gaps in nursing care and advanced nursing care activities. And this is problematic because it means that we are delayed in task shifting and that we have less reach into the community. So these are, I apologize, that's my dog. So really very important in terms of valuing people, recognizing moral distress and supporting and protecting healthcare workers. I'm not trying to repeat everything Jorge said, but equally important is the maintenance of services. So we really need to avoid gaps in services, understanding that there are really competing priorities across all countries and within all populations, particularly in countries that have real challenges such as protracted crisis, that have maybe less robust routine immunization, that do suffer from seasonal outbreaks of issues such as dengue and malaria, and where, for example, we have seen due to COVID and not wanting to have people collect together, there has been, for example, a big decrease in the distribution of nets. And so we can already preempt, and we should be preempting what the next crisis should look like and how we're going to avoid that. So because also bearing in mind, of course, that we're going to see direct consequences from COVID itself in terms of long COVID, but what does it mean in terms of the erosion of gains in HIV treatment, in tuberculosis, in routine immunization gaps, and in other crises that we know that are widespread, such as the climate crisis and the implications of environmental degradation and other issues related to the environment, and what it means, you know, antimicrobial resistance, for example, and how catastrophic would it be that we would end up in a situation where we had bacterial infections that were resistant to the majority of the antibiotics that we have used to have the majority of the biomedical gains that we see in the world today. So I think that these are, we really have many lessons that we can draw from the past, but it is not a case of, and I would like to repeat this, it's not a case of do we know them, it's a case of are we willing to implement them and apply them. And I think that's a big question to the donor community and how they want to address that, including understanding that the majority of health outcomes are dependent on non-healthcare sector. So how do we take that cross-sectoral approach, which has been shown to be the most effective in bringing the pandemic under control, and apply that to more health problems, not just pandemic problems? Because in Africa, we can't think in virtual cases, not even in the, you know, when we have a pandemic. Thank you.
Thank you, Aidan. Very, very interesting explanation of the complex lessons that we have learned and need to use. We'll be looking at the future proofing, as Jorge said in the next questions. But I'd like to take the opportunity to ask Giuliano Russo the same question. What do you see as the lessons that we need to take into consideration when responding to this pandemic and looking ahead as well?
Yeah, thank you, Chico. I think there are two big lessons that we have learned from previous pandemics, particularly from Ebola in West Africa. Number one, that not all pandemics are the same, and therefore you cannot apply the same policy responses to different pandemics, to different viruses. And number two, that while everybody is paying attention to the pandemic, people in Africa keep dying of other things. Yeah. Missing vaccinations, faltering primary care services. So let me take these 2 points in turn. Number one, pandemics are not the same. If you look at the Ebola pandemic, I think Ebola was a very specific pandemic, a very specific virus. The effects, the symptoms of that virus, of that pandemic were very visible. There was a lot of stigma attached to it. Communities really closed down. Borders were shut down. And I think the policy response, the international advice for policy response was, don't do that. Don't shut down borders. Don't shut down frontiers. Keep the economy going, because otherwise this is what will kill the vulnerable. Yeah. With this pandemic this time around, with the coronavirus, it's a totally different proposition. It's a silent pandemic. It's not killing as many people in Africa as we are seeing in Europe or in Latin America. It's a silent pandemic. Lockdown measures seem to work effectively because they really stop the transmission of the epidemic. So I think the policy response needs to be different in this case, because you're not seeing the effects of this pandemic. To the second point, that while everybody is paying attention to the pandemic, people in Africa keep dying of other things. We have conducted a systematic reviews of the effects of pandemics in the last 50 years in low and middle income countries, and we realized that the decreasing uptake of primary care services has killed the most people. It's not the pandemic itself, but it's the fact that mothers don't go and deliver, have babies in primary care facilities. They don't take up antenatal care or postnatal care consultations and visits. They don't take their kids to get immunized. There is a disruption of HIV services. Antiretroviral therapies, cannot be discontinued. That kills people. There has been a discontinuation of diabetes services, TB services. TB services are very effective, but during a pandemic, these get disrupted. And this is what has killed the most people in West Africa. There are beautiful studies conducted in East Africa, particularly in Sierra Leone, in Liberia, in Guinea, showing that what really killed the most people were, these faltering primary care services. Whether that happened, why there was a disruption of those services, whether it was a demand side effect or a supply side effect, I think this is out for contention. Is it that services and health services shut down during the pandemics, or is it that people and women and communities stopped going to the health services, to the health centers and seek care? That is a big question that we need to understand a little bit better. But the reality is that what is killing people and the big risk of for loss of lives doesn't come directly from the pandemic itself, but it comes from the lockdown measures and the impact of these measures on the population and on the uptake of services.
Thank you, Giuliano, for setting the comparison, which we'll come back to with other pandemics. I think it's very important. We'll bring into the conversation Ana Fernandes. Ana, thank you for co-moderating this session with me. I'm going to use you a little bit as a commenter and a moderator for this panel. So if you don't mind, I'd like to have your answer on this, and then you can follow on to the next question as well, if you don't mind.
No, I think a lot of was said already on this first question. I think the complexity of the dynamics here is quite big. I think this last point that Giuliano was also making was very interesting. Are we really paying attention to the things that we need to pay attention? I think that's the question that we need to pose to ourselves. And was bringing the other dimension, which is, okay, if we know that all these are the lessons, why we're not using more the knowledge that is already in developing countries about addressing these challenges, instead of creating kind of the wheel again, because we were not necessarily communicating well and tapping on the knowledge that was already there to manage this crisis. It was kind of I would say, a north-south divide in the way we saw the world, even if we call it a global pandemic. And it's quite surprising that we are not paying attention to the side effects of the COVID and the virus itself. We are very much focused on the north consequences, on the economy consequences. We are not so much focusing on what are the consequences for the health systems and for the other part of the system of health. And we saw the discussions also that we had in some European countries about, the patients that are lagging behind in terms of treatments. And no one is addressing that consequence either. So I think all these questions are very interesting, and I think this is the right segue, if I may, to the second question to our because what we also need to discuss today is a little bit, what can we do? If we had to discuss now what are or what can the international community do differently and better? And if you had the chance to also, propose concrete actions, a call for action that could be kind of a global agenda to address these questions that we have already identified, to support countries, but also health institutions in Africa, what would you propose as a very concrete actions to be delivered? So I would do the other way around now, starting with Giuliano and then going to Anne.
Yeah, sure. Yeah, I think this is the $1 billion question or multi-billion dollar question, talking about the OECD contributions. Look, the reality is that the penny has not really dropped on what the effects of this epidemic are on health systems. We need to understand this a little bit better, because I'm conducting a study in Uganda, in South Africa, and in Mozambique about the health system effects of the epidemic. And what we are seeing is that these effects are in the provision of services, of basic services. But if you look at, for example, the health workforce, if you look at the financing, maybe it's not that evident that there has been an effect. You need to look at the 6 pillars as defined, the 6 health system pillars as defined by the WHO, and see what has changed before and after the epidemic. And what I'm saying is that it's not particularly obvious that every pillar has been affected. For example, there is a resilience, and I very much like the theme of this discussion, resilience of health system. There is an inherent resilience of health systems in Africa. The labor market, for example, the labor market will always attract people, will always attract workers into the health sector, because this is the only sector in the economy that still provides employment, that still provides plenty of opportunities, to be posted in the public service. So paradoxically, and this is another study that we did, worldwide study that we did, during crises, during recessions, the employment in the health sector holds up. It doesn't collapse, not at all. You may have a lot of health workers dying, but there will be always people, and there will always be a turnover, because there will always people trying to enter into that job market. So this is very interesting. So the bottom line is that we need to understand a little bit better how the epidemic is impacting health system before designing interventions. Having said that, I think there are 2 big areas, big ways to go about supporting governments in lower middle income countries to protect their health systems. The first way to go about it is to look at the universal health coverage paradigm and try to compensate the effects of this epidemic on the 3 domains of the universal health systems. Let me just remind you, access to a range of services, coverage of population, and making sure that population don't get into hardship trying to access those services. So we need to address the imbalances that the epidemic has created in the UHC paradigm. A more specific way to intervene is to look at the next phase of the epidemic, the next big challenge, which is obviously vaccination. Everyone is looking, and I think it was mentioned by George before, everybody is looking at vaccines. Everybody knows that the vaccines will be available, but how you create access to these vaccines and to vaccinations, 2 different things, that is the big challenge. Remember, we are in a situation in the world where we are not safe. None of us is safe until everyone is safe. And we need to make sure that in Africa, everybody gets access to quality vaccines and to quality vaccination campaigns. And this is clearly not happening in Africa. And the reason for that is a little bit of what George was saying before, vaccine hesitancy. When I talk to my friends back in Africa, everybody tells me, we're not going for this vaccine that was invented in Europe to kill us. Yeah, hesitancy is a big factor, but also health systems, supply chains, manufacturing of vaccines, of local manufacturing of vaccine is important. We need to step into this area. We need to make sure that African countries can at least produce their own vaccines. That will really lend credibility to their own vaccines for COVID. And this is something that is possible, is doable, but it hasn't really happened in Africa. I'm talking about what is known as last mile manufacturing, making sure that vaccines invented in different parts of the world can really be assembled, produced, distributed, sold, rolled out in the specific countries. There are only 4 facilities in Africa, in Senegal, South Africa, Tunisia, and Egypt, they are producing vaccines these days. This is a big, big gap, because if we keep relying on first world countries discovering the vaccines, they are then manufactured in India, in China, and Korea, and then hopefully distributed to Africa through COVAX facilities or other channels. This is not gonna give the ability to governments to respond and to roll out their own vaccination campaigns. So if I were you, I would definitely try to invest in this last mile manufacturing, fostering, developing for local production of vaccines in Africa. That would also help African countries to, trigger the economic development, the industrial development that they really need. So these 2 big areas of intervention. Make sure that the UHC paradigm is not compromised by the epidemic. And point number 2, look into vaccines and invest in the last mile manufacturing for vaccines in Africa.
Thanks, Giuliano. Very interesting. So I think there is a kind of a consensus around the 3 speakers about the importance of science and the importance of having that, what you call the value chain of access to health and also to access to knowledge, because in the end it's also about who has the knowledge to produce and the capacity to produce science and data, previously mentioned by George. But also, and you also brought this question about the importance of science and the importance of evidence in addressing what we know and in mapping what we don't know. So from your point of view, what are the actions that the international community could take to really address what you identified previously as the gaps, to do it better for the future pandemics?
Well, I agree on particularly Giuliano's point around boosting local supply and manufacturing capacity, but not just of vaccines. I think also of diagnostic and therapeutics, because this will make it possible to basically create a much better geographic spread and reduce the risk that those that it's not just a case of boosting manufacturing capacity. I think it's also around boosting clinical trials. So basically trials held in Africans for African populations, and those same populations that are involved in those trials then having access to the products that are created out of those trials. So this type of thinking about trials, about what that means, the intercultural ability to try and identify what is necessary in different populations, including women and particularly pregnant women in those trials, and trying to ensure that we don't just do trials in Africa, but we do trials for Africa, I think is a very important lesson that we need to both learn and apply. Another thing that I would agree, but I would use it slightly differently, is this idea of last mile. So we would talk about last mile healthcare delivery. So that from the perspective of what are we trying to achieve? Well, in the end, we are trying to achieve that we reduce the number of deaths so that we're saving lives, and that we also reduce morbidity. So the number of people that get severe disease or that are sick. And as Giuliano mentioned, it's not just about the pandemic. We also have other diseases that are concurrently wreaking havoc in African populations, and which African populations have much greater risk of, because of less robust or less well-developed healthcare systems, or access to healthcare systems, and also medical medicines and medical products. So I think this is another area that we need to pay attention to, the different levels of care that we are trying to provide. So it's not just a case of vaccination. Vaccination is important, but we have seen, for example, across the world, gaps in oxygen supply, and in particularly new techniques of supplying oxygen, such as oxygen concentrators. So I think it is the time and the moment to where we don't see a high concentration of COVID cases, or where they are not reported, because I think that we have, going back to data, I think that the data is not that good in terms of what is really the caseload of COVID across Africa, because that would require a much higher level of diagnosis and testing, which we're not seeing. So from that perspective, we really need to think about how can we make those testing available, diagnosis available, also therapeutics. Are we developing therapeutics that can be used and are more accessible, and not basically, for example, even though I with all great respect for the vaccines that have been developed, but an ultra cold chain again reduces accessibility for certain African countries to basically access vaccines that have been developed to date. So again, therapeutics that can be delivered through a much more community-based or primary healthcare orientated approach, rather than just a hospital-based approach. And again, going just to finish the point on the oxygen, ensuring that we are already thinking about and supporting countries on how they can both address and be prepared to ensure that they are able to deliver the healthcare that is needed when it is needed, both for COVID-19, but not just for COVID-19. I think that we also need to think about other issues, not mentioned specifically by Juliano, but there is been a huge, in my opinion, a huge increase in digital literacy across the world, but also within Africa. I think Africa has been a little bit ahead in understanding the real approach and use of digital healthcare and telemedicine and mobile medicine within its populations to greatly increase and enhance accessibility. That does not avoid, of course, the fact that we need also to both appreciate and invest in a more intercultural approach, because Juliano did mention it, and I think it's important that the trust that populations have in healthcare systems across Africa, and specifically in countries that have had rather traumatic epidemic experiences or pandemic experiences in the past, basically has eroded trust in healthcare services. And we have seen that, and we've seen that recently in more than one country, not just around Ebola, but around other diseases. And so it's important that an intercultural approach is really taken, and it is taken seriously, and is made part and parcel of any planning, and really engaging with communities and allowing communities to, communities want to protect their own well-being. So how do we help them help us do that? So really thinking about keeping our eye on the ball, what we're trying to do, which is really, in the end, deliver healthcare. So not just thinking about it from, yes, an evidence-based approach, but really a pragmatic approach on how you can really deliver that last mile delivery of services. And eventually then I do agree that, and I've mentioned this already, but I do agree that I think healthcare workforce is extremely important. They're insufficiently valued, and they're under-resourced, and they're poorly paid, and they're not necessarily very well trained. That, in combination with the fact that I think the international community would be well versed to learn lessons well in terms of what we saw after the 1978 Alma-Ata Declaration, which was on primary healthcare. That is still applicable today, even though what we really saw was, we saw selective primary healthcare be implemented across the world, and particularly in Africa, because it was felt that actual primary healthcare was too expensive. We risk that with universal healthcare, which Juliano has just mentioned as well. We need to ensure that we're not producing healthcare that countries can afford, but really universal healthcare that their populations need. So these would be, and finally, for me, which is very important, is that we think about healthcare from a rights-based approach. So not from a cost effectiveness or a health security approach, because what we have really seen is that health security has been used much more in a preventative measure, that is to keep diseases out of countries, which has not worked in this pandemic at all. And I think that is indicative of the fact that health security should be about securing health for everybody and not about preventing diseases entering certain nations or domains. Thank you.
And thank you very much. That's a lot of what you're talking about is this right to the access to health services. We've spoken about the imbalances between regions, so Africa compared to other regions. We've spoken a little bit about the imbalances within Africa. George spoke about that in the beginning a little bit with, for example, vaccines being very, very concentrated in its distribution. The next question we have for both of you is what needs to be done so to address these gaps in accessing health services in Africa, be it within regions of Africa and also within countries? And since you were on that topic, I'll invite you to start again.
Okay, well, I think one of the key issues here is that we do need to think about healthcare from a rights-based approach. And then that brings us really to health inequalities, which of course, George did mention and Juliana also mentioned. And one of the big problems with health inequalities is they're not caused by health systems. So if we really want to address, you know, how this pandemic came to be and why we have such poor health outcomes across populations in Africa and other parts of the world, we have to address the causal factors with rigor and real political commitment on what are actually causing these health outcomes. And that is above and beyond any healthcare system. It is really to do with market-driven economies, it's to do with global political will, and it's to do with the sort of unsustainable trajectory that we put humanity on. So how do we address that, and how do we address that effectively? And that, I think when we are talking, this is why, for me, I'm personally not very fond of the term resilient healthcare systems, because I believe that by describing healthcare systems within the terminology of resilience, it gives the impression that healthcare systems by themselves can address these problems and can actually bring a solution to these problems. And I think that we have seen and we have evidence that demonstrates that this is not true, that many of the problems that our populations are facing are beyond the healthcare systems, and the healthcare systems that we are putting in place are doing their best to try and address those competing priorities. Now, the other issue I think that is evidence-based and that we need to think about is acknowledging both the benefits of, which are many, but also the limitations of biomedicine and how far biomedicine has brought us and can bring us. And one of the other issues by concentrating solely on sort of healthcare systems is that we tend to try and seek all solutions within biomedicine, and that makes that tends to push us in very technical and very more narrow solutions than is probably feasible. And then I would go back to, again, two issues which I think are really important. And one is intercultural healthcare, which is the recognition that there are parallel health systems, whether we appreciate them or not, that are active in communities across not just Africa, but across the world. And that by working with communities, how can we really create an intercultural healthcare that builds trust and that allows for both a sustained approach to those services that where we're seeing gaps now, so that allow women, for example, to have the confidence to understand that they can still access maternal health care and pre and postnatal care and delivery services during a pandemic or during a different outbreak, and at the same time that they feel confident that there are people in their community that will also and equally be able to support them. The other issue is how we train our health staff, and that again for me is a bit of a problem with the biomedical model, where we tend to teach right and wrong in a biomedical model, whereas of course in many cases things are much more nuanced than that. So cultural competence is also something that we need to provide in terms of training to healthcare workers, I think, which would go a long way towards building trust between communities, treating patients as partners, and basically addressing things like vaccine hesitancy, but also just service access, having people access services that are actually available, but which they perhaps either don't know or have insufficient confidence in. I already mentioned it, but I'm going to mention it again because I think it's so important. We do need to both protect and support our healthcare workers at a greater level than is happening. One of the things that Giuliano mentioned is stigma. And stigma doesn't just apply to those that have had the disease, it also applies to those that are actually treating those that have that disease. And we've seen that across the globe, not just in Africa, that fear really drives community behavior and population behavior, and that can have a very negative effect and can be really detrimental for healthcare workers and people that have had the disease. So this idea of protection and understanding how people need to be protected in their own environments also needs to be built into any type of solutions that we would, when we're thinking about how to address gaps. And again, I think preempting what happens next. So understanding that we have, I know I'm starting to sound repetitive, but these are, I think this is really, I think this is really important. I think we are going to think about, not only do we have COVID, how long will COVID be with us? So at one point in time, will it no longer be considered pandemic, but it will be considered endemic? And then or will it be considered endemic? I mean, it would be wonderful if we were able to eradicate it, but that doesn't seem to be really on the cards at the present time. So what does, what does actually getting people vaccinated to bring this pandemic under control look like? Not only that, but what do catch-up vaccinations for routine immunization look like to prevent further outbreaks and really to support healthcare systems to not be overwhelmed with, as Juliana mentioned, actually excessive mortality and morbidity from other diseases and problems that have not been properly addressed due to the pandemic. Then I think that really scaling up and recuperating gains, again, Juliana mentioned it, not just for tuberculosis and HIV, but also for non-communicable diseases. And I'll just mention neglected diseases, which are often rightly named because they are neglected, but many neglected diseases actually are found in populations in Africa, and in moments like this can get forgotten, but are, but they can have, as we realize one size doesn't fit all, you have genuinely pockets of disease across Africa. And if we forget that we need to think about Buruli ulcer, and we need to think about leishmaniasis and sleeping sickness and different diseases, these populations risk to be even more marginalized and have even less access to healthcare than normal. So acknowledging complexities of different populations, acknowledging the complexities of healthcare barriers to healthcare and how people seek healthcare, including access for more marginalized or invisible populations, which we have across the globe and particularly Africa. I think these are all really, really important elements. And I think most importantly, trying to break this silo thinking of healthcare systems as something that can solve a problem, when really we really need people to embrace and understand that the causal factors of where we are today are greater than healthcare, and they need real political will. I recently read an article that said, if we are not able to manage a pandemic, how on earth will we manage the climate crisis? And I think that is really a note, something to take note of. I'm also very concerned, I have to say, about the antimicrobial resistance that could really distort and wreak a lot more havoc than even the pandemic that we're having today. And for my own part, because it's personally very close to what I do, and I think it's really important, if one of the things that we have, one of the real lessons that we have learned, which is also not necessarily directly related to healthcare, but if we really want to improve and make a difference in the world, we need to educate girls and women. Thank you.
Giuliano, that's a lot to come to feedback on, but I'm sure you have identified in your work how the continent and the rest of the world can help Africa reduce its gaps in access to the right to access to healthcare.
Yeah, look, first thing first, I don't like to talk about Africa in general and African countries, because within Africa we have very different countries with different economic capacity, with different human capital. You have situations like North Africa that is very developed and has developed health systems. You have South Africa, yeah, that is a upper middle income countries with the first open heart and operations were conducted in South Africa, for example. And then you have situations like Nigeria, where people pay out of pocket for their own healthcare. So I think we need to get a more nuanced view of what are these imbalances in access to care in Africa, and what are the drivers for those imbalances. I would say that the pandemic has struck very differently different countries. If we look at the pandemic numbers in South Africa, they are very, very different from the numbers in neighboring Mozambique, as you know very well, or from Botswana even, yeah, or even Nigeria. So I think the way the pandemic moved across the continent matters, and we haven't really nailed it yet. We haven't really understood why certain countries have been affected the most. Is it only a data thing? Is it only because we don't get enough surveillance data from certain countries? I'm not convinced about that, as and neither the WHO is, that it's only a data blip that we're looking at. We need to understand the epidemiology of the epidemics first. Second thing about different access to services. Look, I'm a health system person, and I really believe that the countries that reacted the best to the pandemic are the countries that had public health systems. Public health systems allowed for a coordinated effort. Look at, for example, what happened in India, where there is no public system. It's a disaster. Everybody is doing their own thing. There is no coordinated effort. People have to pay to get their own oxygen canisters from private providers and rush to to private hospitals and beg to use those. I mean, we need public health systems in situations that need to be tackled at a national level. And if you look at the way different countries throughout the world reacted to the pandemic, I think the countries with public systems, it seems to me that the ones that were able to organize a coordinated effort. The example, the United States struggled with the response. Brazil has a Sistema Único de Saúde, a unified healthcare system, but that covers only for 50% of the population. The other 50% goes to the private sector. The balance, yeah, of public and private matters at the end of the day. And to my eyes, this goes some way in explaining the difference in the gaps in access to services. So, yeah, I think the pandemic has made a very strong case for public health systems.
Anna, I'll invite you to comment as well and to start the debate session with some insight and a follow-up question for the many interesting things that have been said here already.
Thanks. Yes, indeed, very interesting. And I was taking note about, if I had to propose some actions to the community of donors sitting in the OECD, what I would say to them tomorrow after this debate. And I took some kind of wording here to make the call for action. I think what I can also say is that we are saying that we need to invest more. And this is not necessarily on financing or bringing more financing on board. We need to invest more on knowledge. We need to invest more on people. And we need to be also investing more in science. And I think that's three dimensions that I would bring to kind of, highlight from the discussion. And here, when we talk about people, both of you refer to the workforces, to the healthcare, but there is also the informal healthcare person that is at home that needs to be also somehow supportive. And we know that 70% of the healthcares in the world are women. So how can we balance that? Because there is the informality of the healthcare and the formality of the healthcare. And I want to bring that dimension here to the discussion. Another dimension that I wanted to bring to the discussion is, okay, access to information, access to the proper healthcare, and access to the therapeutic measures that are needed, and not to forget the whole. And the whole here, it's the whole of health system, but it's also the whole of government system, because there are certain incentives that link, for instance, with procurement. The way the procurement is done in some countries for the health products, it's quite challenging. The levels of corruption around the health system providers, it's also quite challenging. So I want to bring another dimension here to the discussion. We didn't talk yet about stakeholders in this process. We didn't talk about how can we put, but Juliana, you address a little bit that, how can we put the different parts of the system working together here, being the governments, being civil society organizations, being academia, and being also private sector or foundations, which are playing a growing role in the health area. So I think here also there is some kind of work to do, because there's these different stakeholders acting in developing countries and also in some African countries. They don't necessarily coordinate. And they also not necessarily are in line sometimes with the policies provided by either the government itself or even the international community standards. They are acting differently. So I would like to hear your opinion on this. How can we also foster more country level coordination to be much more efficient in the way we deliver and in the way we also create and support the creation of that system? I would like to remind a word from the mandate of the Development Assistance Committee, which is we should aim to end ourselves. So we should, as development community, aim for the day where we are not needed anymore. So what can we do together, the different stakeholders that are part of this global system, to go to the question of, and this is not only about the health part, it's about the overall picture. What is our responsibility on the ground? What should work differently? Just as an example, the donor community meets with the UN. It's very difficult for getting, for instance, providers of development cooperation like China or others to join those coordination meetings. We are struggling to get the same kind of picture of what's happening in the country. If it's difficult for the international community to convene different countries under their own UN representative, I suppose it's sometimes very difficult for the countries themselves to call on these different stakeholders and say, guys, we need to coordinate and we are the leads. So I'm just putting this on the table because I think this is also part of the challenge, and I would like very much to hear from both of you. So again, should we start with Giuliano and Anne afterwards? Please, the floor is yours.
Yeah, a lot of very complex questions on your side, Anne, I had to say. Let me try to break down the different areas that you touched on. Where to invest? I think, as it was said before, I think it was George who mentioned that. I don't think that funds and funding is necessarily an issue in the health sector. There has always been, a certain level of funding, probably not enough, probably not disbursed at the right time, and so on and so forth. But as somebody who has lived and worked in many African countries, I never regarded availability of funds as the key problem in delivering health and healthcare in countries. I really believe in systems. We need to help creating systems, health systems that everybody can chip in from different angles. If we need medicines and vaccines, we can chip into that system from, I don't know, maybe some manufacturers or from COVAX facility and so on and so forth. If we need to invest in people, we need to be sure that there is a training system in place. We can support. If we need to invest in service delivery, or in primary care, we need to know that there are infrastructures and there is a distribution of health centers where they are needed. So I'm a strong believer in system. Once you have the container, it's easier to chip in something that is already there. So yeah, if there is one aspect that we should really start from is in building systems, which is the biggest challenge at the end of the day. I think donors like to have their own flags planted in specific project and say, this is what I've done. And then when you write your reports, you can show some results for the money you have spent. But systems is a holistic view and vision of how to provide health services to a government. So yeah, let's try to get some system thinking into that. Not only in let's get vaccines in the field. Let's train a mother and child specialist, or let's get supply chains and cold chains in place. I think we need a system view on what is needed in the country. Your question about stakeholder is a very complex one as well. It really has to do with the architecture of aid and how certain countries have come to challenge our view of how we should aid low-income countries to develop their health systems, their own economies, their own countries. I think I really welcome that challenge, the challenge brought in by non-aligned, non-DAC donors to the table. I think I wrote something a few years back talking about the new consensus on development cooperation. I really welcome those challenges of South cooperation and so on and so forth. I think I really believe that at the end of the day, you need to enable countries to be up to some point to be self-sufficient in what they do, in how they train their healthcare workers, how they produce, they manufacture their own medicines, yeah, where they get their funds from. I'm a strong advocate of internal funds for health systems. Government have to stop relying on external funds for everything, for day-by-day expenditure. So it's the old Chinese saying, don't give countries a fish, teach them how to fish. Yeah. So yeah, I think it's very important to work on self-sufficiency, and this is the reason why I put forward this idea of creating some local capacity to manufacture, at least to assemble certain vaccines in the African continent. There are some certain functions that cannot be carried out, should not be carried out everywhere in the world. For example, discovering new drugs, discovering new vaccines. Well, I think there are certain countries in the world that have the environment and the human capital to do that. And it would probably be a bit of a waste of time, effort, and money to try to create scientific capacity everywhere, in every single country. I think we have to invest in making sure that the science that is produced in different parts of the world is readily accessible for everyone. So we need to rediscuss trade. We need to rediscuss TRIPS. We need to rediscuss patents, because these are real barriers for low and middle income countries to access IPRs, yeah, intellectual property rights, and the goods that are covered by intellectual property rights. There was a movement until a few years ago that talked about trade, not aid. Yeah, and I think there was some truth in that. I think aid is good and is good for emergency. I think if we enable countries to trade in more equal terms, to create their own capacities, to create their own industry, to trigger the benefits of industrialization, that would probably yield more significant dividends in the long run. There are many stakeholders, as you mentioned, involved in all this. Not everybody comes to the table with similar ideas and with different and with similar power and with influences. I think local governments must be on the driving seat of every negotiation, and we should take our roles of partners in the different functions that we carry out, and let them decide and own development and how they want to go about development. We can bring in expertise from different experiences, but ultimately the decisions need to be taken at that level, not only because I think it sounds like a fair thing to do, but also because the track record of what we did in the past and how we got it wrong in the past when we tried to impose our own ideas of development failed spectacularly. So I think I really welcome this idea that, yes, let's bring different stakeholders to the table. I really think that local governments should be the ones on the driving seat and coordinating and asking for specific inputs.
Thanks so much. I think this is quite comprehensive and very interesting. And it's so interesting to see how we started with COVID, health, and we move now to trade and other agendas that relate so well together. And I think this goes to your point about, the system is a very big thing, and there are things that go beyond the health sector that have a huge impact in the health sector system. So going back to you, and what would be your reaction to my initial question about how do we bring everyone that is working at the country level together? Because that's what we face sometimes, at least from the point of view of the OECD, that is a quite challenging process.
I'm not going to comment on whether there's enough investment in healthcare, but I would agree with Juliana from the perspective that absorption capacity has been a real issue in trying to improve healthcare. So creating it's sort of like a vicious circle. If you provide too much investment and countries aren't able to use it correctly, it looks like, it sort of works against what we're trying to do. I also agree with Juliana that I think public health systems are really important, and they have shown to be a strength, not just in the management of pandemic, but in terms of allowing people real access to healthcare and ensuring that we're not pushing people into poverty through out-of-pocket expenses. Now, that's unfortunately out-of-pocket expenses for healthcare is sort of an endemic problem. Again, I agree that we shouldn't talk about Africa, but in many of the countries, particularly those have a lot poorer populations and poor economic situations, these are countries which really don't have as robust healthcare systems as they could do with. So I would agree with those points. From the point of view of stakeholders, I would say that it's not unusual that people aren't at the same starting point, but it would be really helpful if we could have all of them have the same outcome. So what are we aiming to, what is our end point? What are we aiming to basically achieve together? So if we could have a more common agreement on what that was, that would already be very helpful. And here I think that trade, I think about the market-driven economy, specifically if we want a really good example, the pharmaceutical companies, pharmaceutical trade industry, how all of that is driven is not around so much healthcare and public health systems or the provision of healthcare. It's much more profit and market driven based. And this in itself, how we think about healthcare, this is why I keep insisting that if we had a more health-based approach, then we could think about healthcare much more from a non-profit cost important perspective. So not cost efficient, but cost effective. So trying to think about healthcare from a much more dynamic perspective rather than, in a very black and white terminology. I know we don't use very black and white terminology, but we do tend to hear, even now, again, in the pandemic, we hear discussions about investing in healthcare being cost effective. And I think that that's, we don't necessarily want to seek, we're not trying to make people healthy to be more cost effective, in my personal opinion. I think the other thing about investments is investing in a smarter way. So using those multiple lenses in terms of, how does climate crisis impact? How does access to medical products and medicines impact? How does intercultural healthcare impact? And allowing, as Juliana has said, not trying to have a one size fits all, but really having a population-based approach. So that by definition requires in some countries a national approach and in other countries even a more granular approach, because countries some of the countries that we have with massive populations, such as Nigeria and Congo, have very different populations and very different, require other cultural approaches to really have a more robust public health system functioning. And again, you often hear these days privilege matters, and I think that we've seen that as well over the past 18 months. And the world is not an equitable place, and we don't just have health inequalities, we have educational inequalities, we have inequalities of opportunities. I don't quite agree with Giuliano in terms of boosting manufacturing. I agree that we should boost manufacturing. I agree that we need to seek to really source different manufacturers and also create manufacturing capacity within Africa. But at the same time, there has been a lot of discussion from the scientific community that knows a lot more about manufacturing and supply than I do, that are basically saying we should be thinking of creating hubs. So chemistry manufacturing hubs that allow us to take a stepwise approach to making sure that we can create that manufacturing capacity and actually producing drugs in Africa and vaccines in Africa for African populations. That by allowing these hubs to grow as well, that should also create more opportunities in terms of clinical trials and more research within Africa, which, as we know, would be really helpful because people identify more with research that they have been involved in and they feel reflect them better. And then I think finally, I would say that we really need to think about who's at the table, or, you know, this is another concept you often hear now, who's at the table or who's in the room. And again, in terms of stakeholders, we often think about stakeholders from the terms of the global health care perspective, or a DAC donor or a non-DAC donor perspective. But in reality, what we've seen on the ground is if you want healthcare to function, you have to engage with communities, and communities have to be involved. So not just local governments or not just national governments, but local government, but also community leaders and innovative democracy and finding ways to engage communities and keep populations engaged allows, you know, allowing them to be part of the decision makers, I think can go a long way towards not only creating those healthcare systems that Julio is describing, but filling them in a manner that is not just more robust, but more effective. Thank you.
Thanks, Anne. And I think we only have more 5 minutes to go. So I'm looking to my co-moderator here for guidance. But we agreed that we will put another question to you, but very briefly, you know, if you can come in very briefly with kind of punchy feedback from you. I would ask you, I would like to ask you if you could share with us, based on your, you know, analysis and also your experience on the ground. My point is the following: we always, when we talk about health, COVID, Africa, we are always on this negative lens of, you know, the difficulties, the problems, the challenges. Would you be able to highlight an example where, you know, things are going smoothly and things are going well, and this could be an example of an innovation that we could probably scale up internationally? I'm giving an example. You know, when we were doing a study about the impact of digital in development cooperation, we found out that, you know, we had this question about we should move from the hardware development cooperation to the software development cooperation to be more agile, flexible. And then one of the examples they came across was, you know, I think it's Rwanda that is using drones to make that blood is accessed in remote areas for people that don't have necessarily access to blood. So, you know, and sometimes we just get this reality check that we are still thinking that Africa stopped in time and that it's only about problems. But there is a lot of innovation happening and a lot of innovative solutions happening in all the countries in the world. So I would like to ask you to flag one example in a very brief way of that innovative, positive thing that we could probably pick up and you know, and share with others for lessons learned, because in the end we all have to learn from each other. So Giuliano, I would start with you and then Anne.
Sure. Look, yeah, let's end with on a positive note and with some positive stories from Africa. I think there are plenty of positives. Surely a lot of stories, very good stories that I experienced myself. I'm not really a technology kind of person. I don't really believe that technologies or quick fixes will save health systems. As I said before, health systems are complex systems, are complex issues, and very rarely complex issues are solved by simple solutions. Yeah, but I have to say that there are so many positives that I'm seeing coming from Africa. One example from Mozambique, the country that I lived in and I love to bits to these days. There is the National Institute for Health that has is connected to the Ministry of Health, that has grown exponentially in the last 10 years, thanks to very good leadership, lots of funds from the Americans and so on and so forth. What the INS has done during this epidemic has been incredible. You know, they have been on top of the epidemics, they have been monitoring, they have been running surveys, they have been put together a surveillance system up to the northern areas, even in Cabo Delgado, that, as you know, is affected by the war. It's incredible how that institute, that system has developed, has behaved during the epidemic. Mozambique has not been terribly affected by the epidemics to these days. But I would say that part of the reason we are able to say that it hasn't is because of what the INS has been doing during this epidemic. So yeah, building capacity, very good people, young people working for the INS. They have a new facility in Marraquene even these days, which is outside Maputo. They don't want to be based in Maputo, in the capital area. So decentralization, a good institution, a system in place, a surveillance system, regular updates, good people working for them. It has been a joy to watch. So I think there are success stories that we can rely on, we can tell the world. It's not Africa, the continent. It is, you know, very with this mixed bag of experience can really bring surprising experience to the table. So yeah, very happy to report the role played by the Instituto Nacional de Saúde in Mozambique.
Thank you, Juliana. Thank you so much. And very briefly, because we are already over time, so if you can.
Yeah, I would give basically. I have lots of examples I could give. I think there's lots of really positive stories, huge dedication to people's healthcare and trying to make a difference in Africa. But I think the one thing that I would say, it's not so much something that is done, because there's many mentoring programs and mother care and telemedicine. But for me, I think the most interesting to think about is what we have not learned from these examples. So given that Europe and North America and other countries did so badly in pandemic management, and other countries like Mozambique and Liberia and other countries did so well, what did we study? You know, what does that say about global health? You know, so this idea that everything comes from, you know, I don't like these terms, global north, global south, but this idea that, you know, the global north, so the majority of the global health intelligentsia sits in very well developed countries and sits in what we usually term as the global north. And yet that didn't help us in terms of how we managed this pandemic. However, real experts, people who have suffered through Ebola pandemics, who understand what epidemic outbreaks looks like in populations, these peoples live full time in their communities in Africa. And I think that where global health, if there's a message that we can bring, is that global health needs to be global, and that we need to have lessons learned going both directions. I think that's one of the big gaps that we have today. Thank you.
Thank you, Anne. Over to you, Chico.
Thank you, all three of you, for participating in this excellent debate. I hope it was as interesting for the audience as it was for me. We hope to have you again in a future event of Africa Sessions, all three of you. And for the final remarks, I'll pass the microphone back to my colleague, Assis Malaquias. Assis, the floor is yours.
Well, Chico, thank you so very much to you and Anna for moderating a wonderful session. Let me also thank the outstanding panelists. I was sitting here taking copious notes. I learned a tremendous amount. The participants who attended the session, thank you also very much. As I said, I was taking a lot of notes, and I kept coming back to what I think is the fundamental strategic question that was debated here today. How do African states secure health for all citizens? I think for me, that was the fundamental question. There were some positives, and I was very happy that the panel ended on a positive note. But I also noticed that we still struggle to find positive examples. We mentioned one here, one there, but in a continent of 1 billion people, I think we should mention, we should be able to come up with a lot more. But at least we have some very good and very positive examples. But I think that going back to the fundamental strategic question and how to address it, I think the key, and I was very happy that the panelists kept coming to it, even though a bit tangentially, the issue of governance. The issue of governance for me is very, very important. If we have good governance in Africa, we'll get those priorities right that the panelists were talking about. We'll get those priorities right. How resources are used. I'm happy that the panelists said that the resources are not really the problem. Africa has resources. Financial resources are there. The human resources are there. It's how those resources are mobilized and deployed. How those resources are mobilized and utilized. That's really the key issue. How much of those resources actually stay in Africa, the financial resources, and how much of those resources leak, to use an interesting term, how much of those resources leak out of Africa? Imagine, for example, if those resources were also to stay in Africa and combined with the support, with the aid that comes from the United States, Europe, Asia, and elsewhere. I think Africa would have been able to take steps in a positive direction, a bit better, a bit faster. I was also very happy that the panelists were talking about the interconnectedness of the challenges. This is not just about the healthcare sector. Understanding the interconnectedness of those challenges, understanding the linkages of those challenges facing Africa is absolutely critical. And I'm glad the panelists were talking not just about health, but they were talking about trade, they were talking about investment, they were talking about security writ large. Very, very important. And I think the lesson there is that strengthening those systems is important. If we strengthen those systems, not just the healthcare system, all the other systems, if we take a systemic, structural approach to the issue, we will be able to address those imbalances that the panelists also talked about. The imbalances both within the continent and within countries. So when we put all this together, I think that if we do put all this together, we will be much, much better prepared for the next pandemic. So again, thank you so very, very much, everyone, for coming. The panelists, fantastic. The moderators, absolutely brilliant. We'll do it again. Thank you.